So thank you for that wonderful welcome. So yes, we need to challenge the current system. I trained as a pharmacist more than 25 years ago, and this is not what I signed up for. Amputations. When I started training, I was told the one patient I had who was about 28 with type 2 diabetes was the unicorn. I'd never see another patient this young. Now, 25 years later, when I started, as I said, average age onset type 2 diabetes was about 65. Now it's about 40, and we're seeing children with type 2 diabetes. It's still 20 years from point of diagnosis to serious complications. But what was significant for somebody first being diagnosed in their 60s is extremely different to somebody being diagnosed at the age of 15. We're running out of renal dialysis units. We're very proud of the renal dialysis units that we have, where we can have podiatrists and other clinicians working with the patients to try and help prevent amputations, blindness, renal disease. And we keep throwing more money into the drugs. And that's not necessarily solving the problem. Why did we get into this state? I call it glucosentricity. The irrational belief that lowering blood sugar levels using any available pharmacological means will produce a reliable reduction in blood glucose levels, which will result in health improvements. Now, this was disproven about 2008 with the Accord study that showed that intensive management of blood glucose levels, usually by increasing the amount of insulin that somebody had, resulted in more deaths. So just by lowering the blood glucose levels, we're not necessarily solving the problem. So the big question is how did we get here? How did we have such this huge belief that glucose is the be-all and end-all of diabetes? And we can actually go back to 1500 BC in the Evers Papyrus. We've got the first description of diabetes, this dreadful affliction, not being very frequent amongst men, being a melting down of the flesh and limbs into urine. Life is short, unpleasant and painful. Go back to about 100 years ago, the diabetes wards. People were basically waiting to die. All physicians could do until 100 years ago pretty well was go, you've got glucose in your urine, go home and put your affairs in order. You will die soon, and it won't be pleasant. So 100 years ago, Banting, Best, MacLeod and McKillop came across insulin. And, imagine it. You're a parent, your 10-year-old is on this ward, and these doctors come along with this injection of this new medicine. And they inject your child. And they're injecting everybody as they go down, but before your child is in a coma, laboured breathing, basically waiting to die. But before the doctors have got to the end of the room, your child is starting to wake up, Lazarus-like. You've been given a new lease of life. All we knew at the time was glucose is high, you're going to die. This new infusion of insulin is saving lives. We've got the glucose down, lives are being saved. When we look at the history and the timeline of diabetes management, there's an awful lot about the glucose. I haven't got my glasses on. Was it 1950s? We started really developing some of the medicines. 1980s, home point of care kits. We can measure our glucose levels at home. 2010, HbA1c was really started being endorsed. It's all been about the glucose. If we can control the glucose, we've got 3,500 years of thinking it's about the glucose. But it's not about the glucose, because we now know that strict control of glucose isn't saving lives. What did we miss? Honestly, it's fundamental physiology, but we didn't have the skills, the knowledge, or the technology. We've got all these other hormones running around the body, insulin, glucagon, that have major fundamental changes of how the glucose goes up and down in our bloodstream. And when these things go out of whack, all sorts of things go wrong. So we really have to start thinking that diabetes is more than hyperglycemia. It's way more than hyperglycemia. When we start looking at some of the hormones, now, there's a lot of people don't really understand the difference between type 1 and type 2 diabetes. And so the two groups get lumped into one. And when type 1 diabetes is only 5–10% of people with diabetes, and people with type 2 is, 90 to 95% of people with diabetes. Yes, I'll happily admit there are other small groups of people with diabetes, but essentially we can divide diabetes into people with low to normal insulin or high insulin. And when I say low to normal, that could be a combination of what their body is still producing and what they are injecting from other sources. When we look at C-peptide, which is produced at the same time as insulin in the pancreas, you can really see the difference. People with type 1 diabetes have low C-peptide because their pancreases just don't make it. But we start looking at things like glucagon. We have high levels of both. And insulin. People with type 2 diabetes have high amounts of insulin. It's not well recognised. But when I was training, insulin, it's a case of when we start looking at hormones, there's a normal amount of hormone in the body. Levels below cause a disease state. Levels above cause a disease state. Thyroid is probably your classic example. Well, when I was training, low insulin's a problem because that's type 1 diabetes, and without insulin you'll die. Okay, right, fine. How much is too much? We were never taught this. Most people still don't know. It's a case of, well, it doesn't really matter. We just have to give more insulin to get the glucose under control. But, okay, well, what's the function of insulin? Well, it's just there to get glucose into the cells. Well, it's not. Sorting out glucose is only a minor part of what it does. And actually, you don't need insulin to get glucose into cells. Because every cell in the body has a mechanism by which it will take up glucose with no problems. What we need insulin for is to get glucose out of the bloodstream in a hurry. All right? The average person, I don't know, I'm going to make up some numbers here. They won't be precise because a lot depends on body size and everything else. But if you've got about 5 teaspoons of sugar in your blood at any one time in the fasted state in a relatively healthy person, then you have a concoction that they call a beverage from some of these cafes that contain easily 5 times that amount. It gets into your bloodstream really quickly. Now, anybody ever spilled jam, honey, soda? Who's spilt this sort of stuff? I know I have. How difficult is it to clean up? It's difficult because it's sticky and horrible. Now imagine that in your bloodstream. We've got to get the glucose out of the bloodstream in a hurry. That's insulin's job. It's not to get the glucose into cells, it's to save your bloodstream. But what a lot of people don't realise, insulin's got all these other functions. We understand about glucose uptake, glycogen synthesis, protein synthesis. It's a major anabolic hormone needed for growth. If your insulin's high, you will not make ketones. If your insulin's high, you will not make ketones. Part of the reason for that is if your insulin's high, you will not burn fat. Trying to lose weight, you've got to get your insulin down. Until your insulin's down, you won't burn fat. But what a lot of people don't realise, insulin is actually critical for nerve health. Too much insulin is a problem because you can't make a particular protein that's needed for nerve health. Too much insulin, just as much of a problem. You still can't make that protein critical for nerve health. insulin is actually critical for nerve health. It's critical for blood vessel health. Again, it's a J-shaped curve. Too little is a bad thing. Too much is a really bad thing. Insulin is also really needed for sodium absorption through the kidneys. If your insulin's high, you will retain sodium. So your blood pressure goes up. It's a case of insulin's doing all of these things in the background that's affecting metabolic health. So people with type 1 diabetes absolutely need the insulin injections to stay alive. We measure this with glucose control, but it's not all about glucose control. And the other thing is about good old insulin is these mitogenic effects. When your insulin goes up really high, it changes the way your genes divide. It is really key with a lot of epigenetic expression of different genes. And so we've got insulin as a growth factor, changing genes. Oh gosh, changing genes and rapid growth sounds like a recipe to cancer for me. Upsetting the way our nerves are growing and developing and is needed for maintenance. Upsetting endothelial health, blood vessel health. You know, high glucose, yep, encourages the growth of blood clots. But one of the things about insulin, if your insulin's too high, you can't break down blood clots easily. It impairs the fibrinolytic process. Think about that for your brain. Sounds like a recipe for dementia. Poor blood vessel health, poor nerve health. Doesn't matter which dementia you would like, be it vascular dementia, Alzheimer's type, mixed, different strokes in different places. If our insulin is high, we are sitting on a recipe for all of these things. And that is independent to the glucose levels. So if our insulin's high, we're at risk for all of the complications that we've heard of, and that is independent to the glucose. So this was theorized back in 1920s, that there would be a disorder of high insulin. Theoretically, it had to happen because hormones, low hormones, high hormones, insulin's a hormone. Why wouldn't there be a disease state associated with a high level of hormones? How did we miss it? Honestly, it's because we didn't have the technology. The technology to quantify insulin didn't happen until the 1960s, 1970s. By which point, we already had a lot of medicines and controlling glucose was well entrenched in diabetes management. Joseph Kraft came along in the 1970s. He was one of the first pathologists in the United States who was certified for the quantification of insulin because it involved a radioimmunoassay. They literally had to be signed off by a nuclear physicist to be able to use the new technology. And he quantified over the next 20 years about 15,000 oral glucose tolerance tests with insulin assays and hand drew every graph. I had the privilege of working with Dr. Kraft, and part of my PhD is we looked at people with normal glucose tolerance and looked at what their insulin levels were like. Now, green is somebody with normal glucose, normal insulin levels. Red is somebody with diabetes, presumably type 2. Kraft did not differentiate. It was a 5-hour oral glucose tolerance test. Both people got 100 grams of glucose to drink at time 0. The person with the diabetes was not on any medication. The paler line is the glucose. The darker line is the insulin. A couple of key points. Well, for starters, at 2 hours, there is a 5-fold difference in the amount of insulin the body is producing. People with type 2 diabetes are super producers of insulin. This is not detectable until you put the body under stress. Most tests that we do within the hospital system and the medical system are fasting tests. But that's kind of like you want to buy a used car. You want to see how well the car is going. But you don't just put the car in the driveway and look at it without the engine on. I mean, sure, you can pick up rust. You can pick up leaks normally this way. Right? You know, you can peer underneath it. You can see a bit what's going on. But you turn the engine on. Does it turn on nicely? That tells you a little bit more. But honestly, the best test for your car at this point is to take it down the motorway, put the air conditioning up on strong, and then run it up a hill. What starts happening at this point? So it's the same thing for the pancreas. We can't tell what's going on until we put the body under stress. And also, it's not a quick process. People with type 2 diabetes, you normally can't see how much damage is going on until at least 2 hours down the track. But in this day and age, trying to get anybody to come in for a test that's going to last 2 hours, and you're not allowed to eat during that time, and we're going to make you feel crappy with this massive load of glucose that you're going to get you to drink. People just don't want to do these things. You know, which is one of the reasons why we've moved away from the oral glucose tolerance tests and practices and into the HbA1c. Because trying to get people to show up fasted for a blood test is also next to impossible. HbA1c, it doesn't matter. In the States, scarily enough, you know, with all of this work about insulin, people with type 2 diabetes are producing massive amounts of insulin. A lot of people don't realise. In the States, I hope it doesn't come to New Zealand, but it will, is you get concentrated insulin. Normal insulin concentrations in the vial is 100 units per mil. In the States, you can get 500 units per mil for people who need to have more than 200 units of insulin a day. I don't know how much the pancreas are actually making, but what does a healthy person make or use? Probably somewhere between the realm of between 20, 30 units a day, maybe 50 on a day that they've had some ultra-processed food. And we can work this one out by talking to people with type 1 diabetes who are relatively young, eating a good diet. How much insulin do they normally use? About 20 to 30, and that's out of the honeymoon period. That's about 20 to 30 units of insulin a day. Maybe even a lot less than that if they're on low-carb diets. But that was the amount of insulin somebody was producing, not on any medications. How much more insulin are they needing if they need the 500 units? Coming back to our people, you know, what percentage of the population are affected? Well, when we looked at people with, you know, out of this, I think there was about 7,500 people all up out of the subset of that data set that I was looking at. And the subset was collected in the Chicago 1970s to 1990s. So quite a few years ago. And, you know, other people have probably got the nice weight graphs that show that since the 1990s, our weight as a population, especially in the States, have skyrocketed since then. People with normal glucose tolerance, half of them still had very high insulin levels. Normal glucose tolerance. This won't show up on an HbA1c test because they've got normal glucose. Their insulin's still high. Insulin will go up 10 to 20 years, assuming you're working with somebody who's older than the age of 20 years, before their glucose goes up. If you've got, say, a 15-year-old with type 2 diabetes, they've never known, right from conception, a world without high amounts of insulin. Imagine the damage to the growing brain. We don't know what's happening at this point in time and what a lot of these effects are. People with impaired glucose tolerance, almost all of them had high insulin. People with diabetes, just because Kraft did not differentiate between type 1 and type 2, it looks to be a lot lower. But there's about that, whoops, wrong button again, that 8% of people with low insulin, probably most of those are type 1 diabetes. So now what can we do about it? I'm not going to go into management. Okay, we know the management. We heard all about it yesterday. What works for the brain works for the body at the same time. A lot of it, though, is about we've got to think beyond glucose. We've also got to think beyond when glucose starts going up. This is the point at which we should be doing something about it. Because anybody with a body mass index of over 35, chances are you've got high insulin. If your waist is more than half your height, chances are your insulin's high. It hasn't changed. It's a bit hard thinking about that, but we've got to think beyond glucose. We've also got to think beyond when the glucose starts going up. That's the time to make changes. We've got to start thinking, let's get healthy, not just glucose, but also thinking about the rest of our metabolic health prior to pregnancy. We've got to start thinking about managing, I watch the kids going to school. I've become an avid people watcher, supermarkets especially. Looking at what people put in their trolleys is always fascinating. But when you watch the kids going to school, and these kids, their buttons don't meet in the middle. And they're going into the supermarket to buy their 1.5 litre bottle of sugary sweetened beverages. It's a case of, these children are our future workforce. They're our future carers. They're our future medical professionals. Grant yesterday was talking about people being hangry. It's a question I ask my health science students every semester. Who knows somebody who gets hangry? I always ask who knows somebody. I don't care if they get hangry or not, but if they know somebody, the numbers are growing. Every semester there's always been people. Every semester, 3 times a semester, for the last 5 years, I'm watching the numbers grow. I'm watching the number of embarrassed faces. I'm watching the people who are hiding their can of Monster or whatever energy drink. It just looks horrible from where I'm sitting. I'm watching the people who can't sit through, 2 hours of a lecture. Yeah, okay. Frankly, I don't really blame them. It is a long time. Well, I do 4-hour ones as well, but they can't do the 2-hour ones without needing to eat. But they can't concentrate either, and that's actually a really big issue. So one of the questions, though, I get asked a lot, though, is if insulin's really important, should we be measuring it? And should we especially be measuring the fasting insulin? And I'll sit there and go, actually, no, don't. I might be working with insulin. I might be considered to be a bit of an expert in what insulin does and all the rest of it. But I can tell you it's one of the most frustrating, fickle, fragile proteins going. It is horrible to measure. It's expensive. Save your money. Do something else with it. There's other things that we can do, and I will get to that. But this was people normal glucose tolerance. Okay, so the red line is the glucose. Now, this are American figures. It was an American paper I took this from. So you can see that the red lines are all about the same, which is what you would expect for people with normal glucose tolerance, who all had a 100-gram oral glucose tolerance test and sat there for the next 3 hours. The blue lines are the insulins, and this is based on, this is Kraft's patents. And the interesting thing is, now, Kraft 1 is, for people who are not familiar with Kraft patents, Kraft 1 is normal. You've got a quick response of glucose, insulin in response to the glucose. It's not particularly high. Peaks between 30 and 60 minutes, and by 2 hours later, it is back to baseline. Right, so we've got rid of the glucose, short and sharp, the insulin's back. Kraft 2, we're starting to get a bit higher, a bit slower on the delay. Kraft 3, this one over, 2B rather, it got divided up in some really interesting ways. But remember, Kraft developed these patents using graduated eyeball. If we were to do it now with machine learning and other automated systems would look at these things in a different way. But 2B, we've got big peaks, but we're still dropping off relatively quickly. Kraft 3, this is when we start getting problems. Some other work that was done by Hayashi and colleagues showed that if you've got a delayed peak to your insulin, your chance of developing type 2 diabetes over the next 5 to 10 years is about 40%. If it is your insulin's peaking at 30 minutes and dropping away, it's less than about 15%, possibly even less than that. But at conferences, people will bounce up to me and tell me all about their fasting insulin. I'm polite. I'll say it's fantastic. It usually is fantastic. But the problem with insulin is it's a damned fickle molecule. It's never at steady state. Inside, well, it depends on how well I know the person. I'm often thinking, but what is it 5 minutes later? Because insulin actually oscillates that quickly. And when I did the maths, if you understand statistics, means, standard deviations, people with normal insulin, fasting insulin, 7 microunits per litre, standard deviation of 5. Okay, so normal, 3 standard deviations beyond the mean, so that's 7 plus 15, which is 22. So that means that you could have an absolutely normal insulin still up to about 22 microunits per litre. And that completely overlaps with just about all of the others. 11 plus 7, 16. That's still much higher than the mean, but we don't know where the insulin is oscillating. So you actually cannot tell from a fasting insulin if you are sitting in a normal pattern or a high-risk pattern. And in fact, 20% of people with a high-risk pattern had a fasting insulin of less than 5, which is usually the figure that people are bouncing up to me and saying, my fasting insulin's under 5. Awesome. Doesn't tell me much. We've got to stress the engine because insulin oscillates. The red line is what happens when somebody gets a glucose bolus. The blue line is what's happening during your fasting period. It oscillates like mad. 2 minutes, 5 minutes, 10 minutes, 2 hours. There's lots of different oscillations on oscillations. So what can we measure? Late afternoon glucose and ketones, really important. Time and range, continuous glucose meters. So I'm coming back to the glucose because we can't let go of it, but it proxies the insulin. Now this is my hand drawing. It was done with a scan, so it hasn't come out as great as I wanted. But if pink is glucose, breakfast, glucose goes up, comes back down again. Ketones drop because the insulin suppresses the ketone production. Come late afternoon, if your glucose is back down and your ketones are at a reasonable level, normally at least 0.5 millimoles per litre, you can be fairly confident your glucose has been under control, as your insulin's been under control all day. Or we can look at time and range. Now, it's what Grant was talking about yesterday, people on the roller coaster being hangry all the time. These people have all got the same HbA1c, a useful instrument, but it's crude and it's blunt and it doesn't give you the nuances. If somebody's got an HbA1c of 120, you get it down to 79, that's awesome. But if you're sitting with an HbA1c of 39, how do you know if you're on the roller coaster where damage is occurring, or you're sitting in the green line? You can't tell that from HbA1c, but you can with using a continuous glucose meter. Different tools, different purposes. We have to think beyond glucose. So the future of medicine actually doesn't have to be complicated. If you go back to that slide, it's lifestyle. It's moving away from the medications. What it does, though, is does involve a change in thinking. Thank you very much.